Jaundice. What is jaundice? Jaundice is a condition produced when excess amounts of bilirubin, either more than 2 mg per deciliter or 50 millimoles per liter, circulating in the bloodstream dissolves in the subcutaneous fat, the layer of fat just beneath the skin, causing a yellowish discoloration of the skin and the sclera of the eyes. Important note: jaundice is not a disease, but rather a sign that can occur in many disease types of jaundice. There are 3 types of jaundice: prehepatic jaundice, hepatic jaundice, post-hepatic jaundice. Number 1. Prehepatic jaundice, also known as hemolytic jaundice. It is due to increased production of bilirubin due to breakdown of RBCs. This leads to increased production of unconjugated bilirubin in the blood. But LFTs are normal. Causes: thalassemia, sickle cell anemia, G6PD deficiency, erythroblastosis fetalis, hemolytic drugs, E.G, anti-malarial drugs, sulfonamide, dapsone. Number 2. Hepatic jaundice. It is due to dysfunction of liver cells. Causes of hepatic jaundice: congenital causes, Gilbert syndrome, Crigler-Najjar syndrome, Rotor syndrome, Dubin-Johnson syndrome. 2. Acquired causes: physiological jaundice, breast milk jaundice, hepatitis virus, metabolic, autoimmune, excessive alcohol consumption. 3. Drugs causing hepatic jaundice. For example, rifampicin, isoniazid, pyrazinamide, paracetamol, halothane, valproic acid, flucloxacillin. Number 3. Post-hepatic jaundice, also known as obstructive jaundice. It is due to obstruction of the bile duct that leads to altered secretion of bile. Causes of obstructive jaundice: gallstone, acute bacterial cholangitis, primary sclerosing cholangitis, intraluminal malignancy, cholangiocarcinoma, malignancy of gallbladder, lymph node enlarged, portal hepatitis. Drugs: 1. Steroids. 2. Coamoxiclav. 3. Chlorperazine. 4. Sulfonylurea. These drugs decrease bile duct contraction, extraluminal malignancy causing duct compression, head of pancreas tumors. Following flowchart attempts to explain the mechanism and causes of all 3 types of jaundice. Clinical approach of jaundice: prehepatic jaundice, jaundice plus anemia, due to hemolytic anemia; hepatic jaundice, pain and tenderness in RHC, due to hepatomegaly, nausea, vomiting, anorexia, fever, malaise; post-hepatic jaundice, clay-colored stools, pruritus, weight loss, scratch marks, mass in abdomen. Diagnosis of hepatic jaundice: the yellowing of skin and eyes are likely to be the main clues a doctor will use before confirming a jaundice diagnosis. A physical examination will be carried out to look for sign of swelling of the liver and legs, ankle or feet, which might indicate cirrhosis of liver. Blood tests: 1. Hepatitis virus screening, HBsAg, anti-HCV, anti-HAVim, anti-HAVim. 2. CBC, LFT, RFT, SEPT, APTT, INR, abdominal USG, abdominal quart with 4 contrast and triphasic quart-abd, depending on scenario; MRCP, later ERCP, depending on scenario; MRI, liver biopsy. Note: LFT interpretation method: a greater than 10-fold increase in ALT and a less than 3-fold increase in ALP suggests a predominantly hepatocellular injury. A less than 10-fold increase in ALT and a more than 3-fold increase in ALP suggests cholestasis. LFTs can be requested for multiple reasons: to investigate patients with suspected liver disease, to monitor patients with confirmed liver disease, for example cirrhosis, to monitor the effects of potentially hepatotoxic medications. Liver function tests, LFTs, are among the most commonly ordered blood tests and include alanine transaminase, ALT, aspartate aminotransferase, AST, alkaline phosphatase, ALP, gamma-glutamyl GGT, bilirubin, albumin. Following table shows reference ranges of normal lab values. Alanine aminotransferase, ALT, and aspartate aminotransferase, AST, are enzymes found within liver cells at high concentrations. Raised ALT, AST levels in the blood occur in pathologies that cause liver cell, hepatocyte, inflammation or damage. Therefore, raised ALT, AST levels are a marker of hepatocellular injury. Note: the AST-ALT ratio can help determine the etiology of hepatocellular injury, with a more than 2:1 ratio classical of alcoholic liver disease. ALP and GGT, serum alkaline phosphatase, ALP, is derived from biliary epithelial cells, cells lining the biliary tract, and bones. Raised ALP levels can therefore be caused by cholestasis or bone disease. Gamma-glutamyltransferase, GGT, is found in hepatocytes and also biliary epithelial cells. It is a non-specific but highly sensitive marker of liver damage in cholestasis. ALP and GGT are interpreted together to localize the source of raised ALP in the blood. An ALP rise with normal GGT suggests bone disease, for example Paget's disease, vitamin D deficiency, bony metastasis. An ALP rise with associated GGT rise is more suggestive of cholestasis. Hint: an isolated GGT rise is classically associated with alcohol excess. Bilirubin. Bilirubin is a waste product of hemoglobin breakdown. It is predominantly metabolized and excreted by the liver. Raised levels of bilirubin in the blood will lead to a yellowing of the skin, known as jaundice. Jaundice is usually absent until the bilirubin level exceeds 50 micromole liter. Raised levels of bilirubin in the blood can be caused by excess bilirubin production, prehepatic jaundice, a breakdown in bilirubin metabolism, hepatocellular jaundice, a blockage in the bile excretion pathway, cholestatic jaundice. Albumin is used as a non-specific marker of the synthetic function of the liver. Albumin levels can fall due to decreased albumin production, malnutrition, severe liver disease, increased albumin loss, protein-losing enteropathies, nephrotic syndrome. Now to summarize interpretation of LFT serum, total bilirubin will rise in all three types. Unconjugated bilirubin will rise in prehepatic and hepatic. Conjugated bilirubin will rise in hepatic and post-hepatic. ALT and AST will increase only in hepatic cause. ALP and GGT will increase in post-hepatic cause. GGT will also rise if hepatic causes alcoholic hepatitis. PTA-PTT will increase and albumin will decrease in hepatic cause. This is due to decrease in synthetic function of liver. Management. Treatment depends on the cause of the underlying condition leading to jaundice and any potential complications related to it. Once a diagnosis is made, treatment can then be directed to address that particular condition, and it may or may not require hospitalization. 1. Treatment may consist of expectant management, watchful waiting, at home with rest. 2. Medical treatment with intravenous fluids, medications, antibiotics, or blood transfusions may be required. 3. If a drug, toxin is the cause, these must be discontinued. 4. In certain cases of newborn jaundice, exposing to phototherapy or exchange blood transfusions may be required to decrease elevated bilirubin levels. 5. Surgical treatment may be required in case of obstruction jaundice. Treatment. Supportive care. 4. Fluids in cases of dehydration, medications for nausea, vomiting and pain, antibiotics, antiviral medications such as acyclovir, blood transfusions. 4. Autoimmune hepatitis, steroids, immunosuppressants. 4. Chronic hepatitis B and C, interferon and direct-acting antiviral medications. 4. Fulminant hepatitis and end-stage liver failure, liver transplantation, liver cancer, chemotherapy or radiation therapy. Neonatal jaundice phototherapy.